Hi, so I am here in image anyway. My video is camera is malfunctioning for the moment. I have to go to the Apple store. But I'm here with Jaime Seltzer, who I think many of you will know. She's pretty active on social media, and she is the director of scientific and medical outreach. Is that the right title at ME Action? And
That's
so
correct.
I wanted to have her on because we've communicated a lot for a long time, and I just wanted to, because ME Action's involved in a lot of stuff, and I wanted to find out what exactly Jamie's role is and how she got to that role, and sort of, what she sees her role is, and some of her thoughts on some of the things that are going on at the moment. So, Jamie, thanks for being here, even in the absence of my actual face.
Thank you for having me.
And so tell me just first about what your own health status and then how you got to sort of become, working with ME Action.
Sure. So I have ME, and I would say that my presentation without any meds would be moderate. Right now, I would say it's minor moderate because of what I do and what I take. I have a really
Do you want to just tell people what you take, or
Oh
no?
gosh, if you want me to, sure. I do a lot of things that are antioxidants, and maybe that's why they're helpful. B vitamins, I unfortunately I compound my own B vitamin mixture because I could not find a pre-made formula strong enough or easily absorbable enough.
Mhm.
I take pretty high dose CoQ10, which hopefully is helping with mitochondrial dysfunction, but you never know why things work.
Right.
Vitex, Agnus castus, for breathing issues, air hunger. Lactoferrin for immune dysfunction. Let's see.
Okay, that's a pretty good list. So just to be clear,
Yeah,
this is
a
not
lot.
this is not a medical recommendation. This is purely Jamie's own thing. So please don't anybody take this as any kind of medical recommendation for anything.
Thank
Uh,
you.
just to make that clear. Okay, so you're feeling sort of on a moderate level, or mildly moderate.
Yeah.
And so how was it?
Um,
And when did you get sick?
I would say that I got sick probably about 10 years ago, maybe a little bit longer at this point. Um, and when I got sick, I would probably characterize my symptoms as more severe. I was bedbound for extended periods of time around onset. And despite the fact that my mother had a diagnosis of CFS from the 90s, we did not know that we had the same thing because the presentation is pretty variable, right? You know, your top 5 most concerning symptoms are not the next person's top 5 most concerning symptoms. We were surprised to hear that it was the same thing. And then I was doubly surprised to hear that my oldest sister had been diagnosed with ME/CFS and had just never mentioned it to anybody.
Oh, okay. So there's a
Yeah.
familial connection that we do see in other cases. So how did you get involved in with ME Action, and what is your role exactly there?
Well, I was originally on Phoenix Rising when ME Action was taking off. I was one of their first hires, and I was hired to be managing editor. I got more and more into the science and summarizing the science. I remember I had in 2016 written a relatively well-received analysis of one of Navio's papers that went into more depth. I went to IACFS ME conference and I met Ron Davis and Linda Tannenbaum and was hired from there to work at Stanford for just over a year at the Stanford Genome Technology Center with his research group.
And that was what year?
I want to say 2017, 2018,
So you started working for ME Action around.
2016.
Okay.
And I will say, like in advance, that one of the ways my cognitive dysfunction manifests, even in the short term, is that I have a great deal of trouble with dates. So I had a crash earlier this week, and I have been telling myself over and over again what day it actually is because my brain misinterprets the amount of time that's passed.
Okay.
So if you see other dates somewhere else, it is
I won't
not
hold,
an intentional omission.
we won't be holding you to anything, any dates.
Thank you, but that's approximately correct.
Approximately is fine for these purposes. So, okay, and so then you started working with Stanford Group.
Yes, and did that for just over a year, and then came back to ME Action in the director position. And I still do hands-on research with Stanford as well. I have 1 day a week that's for consulting.
And you have a science background yourself?
Yeah, I have a bachelor's and a master's degree in scientific fields, unusual scientific fields, and an education background as well, a pedagogy background. My graduate degree was in clinical alternative medicine because I had watched my mother got sick and have no recourse. Nothing that clinicians told her was helpful. They didn't even know what was wrong with her. And I wanted to figure out a way to help people that was maybe outside of that failed system.
Mm-hmm. And so what is your role with ME Action?
So as Director of Scientific and Medical Outreach, I do a couple of different things. I speak to researchers about infection-associated chronic illness, and I include long COVID in that. I've created continuing medical education for MECFS. I have served on committees and for various government agencies, including World Health Organization and some Australian organizations, some UK organizations, but NIH and CDC for people who are more familiar with the United States work. And
you're on one of the Cochrane committees for the
yes, I'm also on the IAG, the Independent Advisory Group for the Cochrane review. So oftentimes I serve as the voice of science and clinical care, but with lived experience behind it in various different contexts and situations.
And so that's helpful to have the combination of the lived experience, or to be able to talk with people who don't understand the phenomenon or don't quite get it, that you have both hats, so to speak?
I think it really matters. And I've seen some research too that specifically points out that when it comes to rare or rarely diagnosed diseases, people with lived experience are the experts. It's not something you say to patients to make them feel good. Their experience means that they often have more knowledge, more background than the average researcher or clinician does. And it can be especially meaningful too in arenas where people experience stigma, like diseases that predominantly affect women, like diseases that relapse remit, and like diseases for which there's no FDA approved treatment. These are the diseases that tend to be marginalized and
for which
really need that voice.
For which there's no sort of single diagnostic test as well. I mean, that's sort of.
Yeah, no single diagnostic test is a great way of putting it, because although there are things that we can find off or irregular in people with ME, so far none of them are unique to ME.
Right.
So, you might find natural killer cell dysfunction, but you see that in other diseases and disorders as well.
Right. What's your sense about the impact overall of long COVID? And I guess I'll sort of, why are we having, again, this kind of seeming conflict between these kind of really two somewhat opposing ways of viewing this phenomenon of post-viral illness, or this phenomenon that everybody agrees happens, that after infections, a certain arguable percentage, but some small percentage, have sequelae that are hard to explain, but that are persistent, and that's pretty consistent across epidemics and just across, spontaneous cases of viral illnesses. And here we have a worldwide sort of evidence of that, and it gets pushed back as this kind of psychogenic, psychosocial strain once again.
So is the question, why do I think that happens?
I guess the question, that was just really not even a question, I guess I could say. It was just sort of my formulation of my observation. But I guess, yeah, why do you see that? One, do you agree that we see that happening? And two, why do you think that happens? from
Well,
your
I'll tell you
perspective?
something interesting that I've observed. I've been working far more often with clinicians and researchers, I would say, since the start of the pandemic. And what I notice about clinicians is that they fall into two distinct groups. Some of them believe that psychogenic medicine is everywhere. They see it in everything, especially in problems that they personally can't solve. And they firmly believe that all other clinicians also think this way and also use psychogenic explanations to plaster over problems that they have trouble solving.
I'm nodding just so you can't tell, but I'm nodding and I'm thinking you can see that, but you can't, but I am nodding as I hear you talk.
So then the other group is very open to learning more about this. They're beginning to recognize, like, they see a pattern of similar symptoms in patients after infection. And some of them are even saying, actually, it's just like what I saw when I had this patient who had mono, who had like really long symptoms. They're beginning to put it together. They likewise think that all other clinicians.
They're making some connections from their own past clinical experience of things that they didn't quite maybe get at
Right.
the time.
It's like it's all coming together in their heads that this phenomenon that's now much more clear and obvious than it used to be is actually something that they were seeing drips and drabs of throughout their career all along. They are very open to learning new things. They believe that this is a serious disease. While they might recommend talk therapy because it's really hard to have a new chronic illness, they don't believe that that will cure it. And they think that all clinicians believe as they believe. They're equally as convinced that everyone's on the same page as they are, as the handful of people who are of a more psychogenic sort of mindset.
Mm-hmm.
And it's very interesting to work with both groups of people because they are they're just so sure that the way that their mind works and the way that they conceptualize a problem is simply identical to the way that anyone would. That's that's normal, right? That's human. The way that my brain works is the way that everyone's brain works.
Right. But the problem seems to me that what seems to me is that they're saying is that, well, we can all agree that mood disorders might lead to some physical symptoms, or people have panic attacks, and we can all see that and we can all agree with that. But then they extrapolate that to suggest that when we don't see exactly what is causing something in the pathophysiological sense, we can assume, because we know that's possible, we can assume that it's being caused by those factors. That seems to be the argumentation that they're making, which doesn't make a lot of sense to me.
Well, there are two major issues with that. And the first is that we've got a sort of slippery slope sort of fallacy. Like, if getting anxious can cause an elevation in heart rate, then getting anxious can cause you to have cancer. Those
Right.
don't follow. And ME/CFS is a multi-system disease. It is classified as neurological, and because of that, it shows up in everybody's system. It's pretty profound for anyone who might be reading an interview and not being completely familiar with the disease entity. So it is, in and of itself, that is not a logical, sense-making kind of thing.
Mm-hmm.
The second thing is it's an evidence of absence argument. If you're going to actually say that every single human disease should be spotted by the, 10 or 15 pieces of blood work you do when you do run standard labs on the patient, have I got news for you about like the rest of medicine and human health? That's nonsense.
Right.
And I think that when a clinician is saying that, what they're really saying, whether they understand that or not, is there's something about you I don't find credible. And that's where things like misogyny and racism kind of come into play.
Well, and also when some of the studies that show that doctors make these decisions within a very, very brief period after just
very brief
before
seconds.
a test.
Yeah. It's based off of your first impression of the patient. And I know which studies you're referencing, and one of the grants that we're working on this year is through the Society to Improve Diagnosis in Medicine, and it's their job to attempt to change the way that this happens. One of the ways in which you can shift this is by including diagnostic algorithms in your work and prompting clinicians to go down a list of questions and tests one at a time, and not ask them to use that snap judgment, which lots of people trust their gut, but the gut lies.
Mm-hmm. But I mean,
Um,
part of what we're paying doctors for as well, though, is their expert clinical skills, which relies on their judgment. And so it becomes a real challenge when clinicians, and let's not say doctors, but when the medical healthcare system, say, is convinced that a diagnosis is this, it's very hard in some ways for a doctor to sort of counter that, I think, or they do come to it with a certain mindset, and they do, I think, often genuinely believe this is what they're saying, what they're telling you it is. I mean, I think we use the term gaslighting a lot these days, and I'm sort of trying to separate between those who are really deliberately distorting their research,
mhm.
which happens commonly, and just the average doctor who is not. It's not gaslighting. The system may
They're
be
just
gaslighting,
mistaken.
is
Yeah, there's a
mistaken,
difference between mistaken and gaslighting, for sure.
which
The
doesn't mean they're
patient
not
may feel
working.
gaslit.
Right. It doesn't mean that the effect on the patient's any different, but the intention of the clinician might be different.
Yes. And I think that for clinicians who are struggling with the idea that there might be this multi-system disease that they haven't seen before, or haven't dealt with yet, or maybe even have dealt with incorrectly in the past, there is always time to change the way that you address a particular disease or a particular subset of patients. There's always time to learn. There are decent CMEs about there about MECFS, continuing medical education courses. And it really is it was this very quiet, smoldering epidemic before COVID. And now infection associated chronic illness is everywhere. And if you are a clinician, it absolutely is your duty to learn more and to learn from sources that have involved patients in their creation, because it's just very tempting to pick solutions that are low cost and low effort over those which tend to actually have the greatest positive outcome and lead to the greatest improvement in quality of life for patients.
Well, how do
You
you
want to pick something that works, not something that's easy.
How do you counter the argument that's been made that, well, this is sort of a long COVID's a patient-created syndrome, and there was the sort of, Wall Street Journal editorial that referred to it was created by a queer feminist wellness collective, which was sort of used as de facto to mean if it was, quote, created, or the study was done by a queer feminist wellness collective, of course it must by definition be illegitimate.
Mhm.
But what about
Well, I want to break that apart before you even end the question.
Mhm.
That's an attempt to use queerness
Yes,
and
and
women
women. It was
as a
misogyny.
way of discrediting, research. Like, listen, if you're gay, or if you're a lady, you can't do real research, which in and of itself should make people question that framing. That's awfully weird. That's
Yes,
an attempt to say those weird radicals came up with something.
yeah. I mean, that was so, but just in general, the idea that this is all sort of patient driven, or this is driven by, essentially patients run amok, and, doctors not being able to gently tell them, the truth about their condition, that they don't have any underlying pathophysiological illnesses. Um, this is really a debate now that's come up in a quite high profile way in, major magazines.
Kind of. I mean, only because it's very profitable. It's a very profitable frame for certain people. That is not a scientific argument. That's a political one. We can still address it, but I want to make that perfectly clear, that the idea that, like, because certain people say it, it must be wrong, that doesn't address the science. That doesn't address medicine. That is you can't trust those crazy lefties. So let's break that down a little bit.
Well, I
First,
just want to say, yes, I mean, I agree that the arguments that are being made have a lot of holes in them.
yes.
However, they are being made in high profile venues that a lot of people read, and so are potentially influential. Although the arguments, the ones that have been in, say, the New Republic in New York, if we're talking about those, have presented their view as the minority view, or as kind of the the out of, out,
Well,
even
not just the minority view, they have
though,
presented themselves as the minority
right.
in order to attempt to claim the umbrella of protection from criticism. We're just a little guy. We're just a little guy in the Wall Street Journal. Yeah.
Yeah, so
I think I have enough to address this unless you
go ahead.
wanna.
No, go ahead.
Yeah.
Go ahead.
So first of all, we certainly have this mainstream idea that science and medicine occurs apart from society and in this little space of rarefied air that only specific people with specific backgrounds get to breathe. In real life, where, all patients and all clinicians and all researchers live, the progress of science and clinical care is not a straight line of elderly white men marching in lockstep. If you look at HIV/AIDS and the history there.
Hello, yes, gay man from the 66-year-old gay man. I was around in New York in the 80s, my whole 20s.
That's right. So, when we're looking at that, we recognize that no, it wasn't just like the natural progression of science that helped come up with the first drugs for HIV. It was patient driven. It was driven by queer collectives. It was driven by the sick people who were affected. And that's not unique to AIDS, HIV. That's not unique to long COVID. That's not unique to ME/CFS. There has always been advocacy around healthcare, and there always will be if we ever hope to make any progress. The phrase "nothing about us without us" is very pertinent here. If the people who are the most affected do not have a say, then they are not being served, we're not helping people, and we are certainly not operating off of the best possible information. Again, this is not just a matter of making patients feel good. The patients have the information that science needs.
One of the things that I want to run by you, since you mentioned the HIV situation, is I remember very well being sort of a privileged white middle-class gay man at the time, that it was the privileged middle-class white gay men generally who were so shocked at the loss of privilege by becoming sick and realizing that their insurance wasn't covering them and their doctors didn't want to see them and their families were rejecting them because they'd always been somewhat closeted, but now that their privilege didn't protect them. And I think I've seen a little bit of that similar, and so they pushed the envelope a lot in terms of ACT UP and doing really aggressive activism. And I've seen a little bit of that in the doctors with long COVID, who again
Yes.
are shocked at the treatment they've gotten from their colleagues in some cases, and can't believe that they're being told this must be anxiety and depression when they know very well the difference between what they're feeling and anxiety and depression, of a normal whatever. And so I'm sort of wondering if you see those, they can't do as much because they're sick in a way, but they're active online. They're trying to push the envelope as well, and sort of use their experience to sort of push forward the argument that, this is something we need to pay attention to.
I absolutely agree. And we saw this too in the royal free outbreak of post-viral ME/CFS. A lot of nurses and doctors were affected, and it's obviously the same here because we had people who were hospitalized with COVID, and that's how our clinicians and other medical providers became infected, and certain percentage go on to have long-term symptoms. I have heard out of the mouths of many doctors that they're just absolutely shocked at how they're being treated. You can come in and have a scientific background or a clinical background, and if your reported symptoms don't match a certain number of check boxes, you can end up being dismissed. I've heard the same out of the mouths of many nurses that I know, and I think there's definitely a bit of shock and
Yeah,
a little bit of
this can't be happening. You can't treat me this way. I am X or I am Y.
well, and I am one of those good people. I'm not one of those chronically ill, disabled people that I also may have been dismissing all along. There's a bit of realization there too, like, oh, is this what everyone I talk to is actually going through. And I think that that's hard. I mean, the experience of being sick is horrific in the first place, being this sick, but also sort of feeling like you're losing a certain brotherhood with your profession. You have left this country of able-bodiedness and entered a place that's very unfamiliar and feels very threatening.
Especially if you got sick on the job when you were sort of pushing in there because other people weren't available and because there was a
Right.
crisis. We're coming to the end of my, allotted 40 minutes here, actually, even though we were talking a bit before. So, and we've covered a lot of ground and we didn't talk about things that I wanted to, but I think we've left something for people to think about anyway. And again, I've been trying to keep these on the shorter side so people can listen and not have to listen forever. So I'm going to end it, and I think we left people with some things to think about. And I really appreciate your being on the air with me, Jamie. So I'm going to end the recording. Right.
Absolutely. Thank
Hold
you
on.
for having me.